Dr. Kapoor, you're recognized for 5 minutes. Please summarize your opening statement.
Chairman Burgess and Ranking Member Green, thank you for inviting me to speak in support of H.R. 2557, the Prostate Cancer Misdiagnosis Elimination Act, sponsored by Representatives Bouchon and Rush. My name is Deepak Kapoor, and I'm a practicing urologist specializing in the care of urologic malignancies, including prostate cancer. I'm also Chairman and Chief Executive Officer of Integrated Medical Professionals, the largest independent urology group practice in the country, as well as Clinical Associate Professor of Urology at the Icahn School of Medicine at Mount Sinai Hospital. Issues related to prostate cancer are of particular concern to physicians in my group. 1 out of every 80 men nationwide diagnosed and treated with prostate cancer is managed by one of my doctors. About 1 in 7 men diagnosed with prostate cancer will be diagnosed with prostate cancer during their lifetime. This diagnosis is usually established by a test called needle biopsy of the prostate. We rely on the results of this biopsy to counsel our patients on what treatment options are available to them. The modern promise of precision medicine and targeted therapy requires complete and total diagnostic accuracy in this test. However, despite best laboratory practices, the clinical literature has recently revealed a troubling persistence of prostate biopsy complications, where a relatively high number of specimens have been switched or contaminated with tissue from another patient. These are known collectively as specimen provenance errors. The reason for these errors is that the workflow for prostate biopsy is extremely complex. The chart before you shows 10 different places within the diagnostic testing cycle where a patient's sample can be transposed or contaminated by another patient's tissue. These errors can result in the patient getting the wrong diagnosis and, tragically, inappropriate or unnecessary treatment. The literature shows these errors are frighteningly common. A 2015 study documented that over 2.5% of biopsy patients are subject to specimen complications. Perhaps even more troubling, the study concluded that at least 1.28% of patients newly diagnosed with prostate cancer actually did not have cancer at all. As noted in a recent New York Times article, these medical errors have traumatic consequences on patients. Patients inaccurately told they have prostate cancer are subject to expensive, invasive treatments such as surgery and radiation therapy. Patients, on the other hand, who were inaccurately told they do not have cancer may miss a narrow treatment window because the cancer is not diagnosed in a timely fashion with potentially fatal consequences. There is a simple way to eliminate these errors entirely: DNA fingerprinting with a DNA specimen provenance assignment test, which definitively rules out switching and contamination errors that could lead to prostate cancer misdiagnosis. This process involves obtaining a sample of DNA by a simple, non-invasive swab of the patient's cheek and comparing that reference test to the DNA found within specimens found to have prostate cancer. In this fashion, all 10 points of potential errors in the diagnostic testing cycle are completely bypassed, and the provenance of the specimen is 100% verified. To improve diagnostic accuracy and eliminate medical mistakes, our practice changed our treatment protocol to require a D-spot test, the provenance, which is the abbreviation for the provenance test, for all positive biopsies to ensure the right patient receives the right treatment, or where it's appropriate, does not receive treatment at all. Importantly, this service is performed by an outside laboratory and not billed by my practice. There is no financial incentive for our physicians to order this test. Not only does this test improve patient care, but elimination of diagnostic errors will lead to savings to the Medicare program. According to an April 26 study by Milliman, potential savings to the program from eliminating medical errors would be at least $539 million over 10 years. D-spot testing is widely used today. More than 60,000 prostate cancers per year receive the test and is offered by many labs. In 2013, Medicare acknowledged that D-spot testing is very useful as a tool for avoiding error and misidentification of a patient with cancer. Despite this acknowledgement, Medicare asserts that it does not have the authority to pay for D-spot testing because it does not explicitly diagnose or treat disease. This debatable interpretation of the Medicare statute is wasteful of Medicare resources and harmful to patients. Congress can solve this problem by enacting H.R. 2577, the Prostate Cancer Misdiagnosis Elimination Act, which would require Medicare coverage for D-spot tests for positive biopsies. The bill has the full support of the entire prostate cancer provider community, including the American Urological Association, Large Urology Group Practice Association, the Men's Health Network, the Prostate Health Education Network, the Vietnam Veterans of America, and Zero, the End of Prostate Cancer, to name but a few. I urge Congress to seize the opportunity to eliminate thousands of preventable medical errors, improve the health care of American men, and reduce the cost of the Medicare program by enacting this bill. I thank you again for your time and attention.
Thank you, Dr.
Kapoor.
Kapoor.
On the biopsies for prostate, how often in your best estimate, do you think the errors in the needle occur, or errors in needle biopsy occur? How often does that happen?
Well, it's important to understand that the error is not precisely the biopsy, it's in the analysis of the biopsy, in the diagnostic testing cycle. So the biopsy is
Oh yeah, I said that wrong.
But the data shows that it occurs in about 2.5% of cases overall, and unfortunately, nearly 1.3% of the time, the patient doesn't have cancer. Importantly, the literature...
Is it always false positive? I mean, always false negative, or is it, or false positive?
It can be either way. Because
So
whenever,
some people don't get the treatment they need.
It depends on the type of error, because sometimes tissue can be contaminated from another patient. Other times the tissue can be completely switched, so that patient A is being diagnosed, given the diagnosis of patient B, and vice versa. So the person that's being read as negative actually has cancer, and there's somebody else that's being read as positive that doesn't. And this does occur in other malignancies as well. You know, there was a notable case on Long Island where a woman had unfortunately had a bilateral mastectomy because of a switching error. It's just because with prostate biopsies, we do 12 to 20 cores samples per patient as opposed to 1 or 2, that the errors are magnified because there's just so much more tissue that is being handled in a prostate biopsy.
Okay, thank you very much.